presentations. So our Lunch and Learn title is Gestational Diabetes in Bradford, and our guest speaker is Penny Beddoes, the Anaesthetic ST6 Chief Registrar for Bradford Teaching Hospital. And I'll pass it to you, Penny.
Hi, my name's Penny. Thanks for having me. As I mentioned, I'm one of the anaesthetic regs here at Bradford. I'm specifically interested in obstetric anaesthesia and enhanced maternal care, and working in the role of Chief Registrar at Bradford this year. I've come to talk about gestational diabetes in Bradford, and I'm going to start by saying that as a non-endocrinologist, diabetes is not an area of expertise for me, or has not previously been. But my interest in this area arose both because of my clinical interest in obstetric anaesthesia and obstetric medicine, but also because of some work that I've been involved in this year in my role as Chief Registrar. And that's led me on a bit of an evidence deep dive. So what I'm presenting today is the sort of fruits of that evidence deep dive. So as an anaesthetist on labour ward, I, as well as putting in epidurals and helping with C-sections and spending my time rolling eyes about cannula requests, I make up part of the MDT, who review women on labour ward rounds. And of all the women who have babies in Bradford, unfortunately, a number will, at some point in their pregnancy or as part of their delivery, become sick enough to need higher levels of care, with additional monitoring or even organ support, either in the form of enhanced maternal care on labour ward or, more rarely, in the critical care unit. At Bradford, this is around 11 to 12% of women, which certainly when I started looking at this data, I was really surprised by. As an anaesthetist who also covers critical care, it's a group of patients that I often become involved with. Around 10 years ago, Debbie Horner, who's one of the critical care consultants and anaesthetic consultants at Bradford, set up MIAC, which stands for Maternal, Enhanced and Critical Care. MIAC defines standards of care for women who need enhanced or critical care. It sets training and competency frameworks for midwives who want to gain further training in the care for these women. And as part of MIAC, we also collect data for these this 1 in 10 women who become significantly unwell, something that's done across Yorkshire and Humber, for which Bradford is the data controller. Despite this being national guidance, we're currently the only place in the country to do this systematically. So we've been uniquely placed to delve into this surprisingly large group of women who get sick and look in greater detail at their characteristics. There are some clear trends. Firstly, that postpartum hemorrhage is the #1 reason that women get sick, which probably doesn't surprise many people. Secondly, in line with recent Embrace reports, there exist significant inequalities among who gets sick, with Black and Asian women at a regional level being more likely to need enhanced or critical care. The other thing that stood out from the data was the really high prevalence of gestational diabetes among the MIAC cohort. At the very core of the MIAC project is quality improvement, and we wanted to make sure that as well as reporting our data, we use it to drive forward work that addresses the issues that are faced by our local population. So over the last year, a new organisation, which is brought together by Mike McCoo and the Improvement Academy at Bradford, has been launched with this exact aim in mind, and this is called Bambina. Bambina is a collection of people and organisations aiming to improve care and outcomes among the maternity population in Bradford. We know that maternal morbidity and mortality are rising in the UK, and that safety and maternity care has been in the spotlight for quite a long time. Shockingly, there's not a single trust in the UK that rates as outstanding for safety in maternity care. We also know that significant inequalities exist in maternity care, with women from Black and Asian and minority ethnic groups, as well as those experiencing social deprivation, having much worse outcomes, with Black women being 3 times more likely to die during pregnancy or shortly after than white women. Bambina aims to unite existing resources in the city in recognition that these outcomes are really multifaceted in origin, and addressing them will need interventions that span across services from public health, primary care, all the way through to the intensive care unit. While study after study has reported issues with inequity, it feels that there's a lack of action or direction for how we actually address this, and this is the gap that Bambina hopes to fill. As a group, we've chosen gestational diabetes as a first point of action. We chose this because we can see from our data at Bradford that not only are rates of GDM in our maternity population rising year on year, but also that these women are overrepresented in the cohort of women who get sick enough during pregnancy and childbirth to need higher levels of support in hospital. Gestational diabetes is also overrepresented among those of Asian ethnicity. Despite this, it can feel that there is a bit of an apathy from healthcare providers about our ability to intervene or prevent this. Again, this is something that we would like to challenge. I'm going to talk through some evidence about gestational diabetes, the current diagnostic and management pathways, and the beginning of how we hope we could intervene in this. Gestational diabetes is rising in prevalence globally. In the UK, it affects 7% of pregnancies, but in Bradford, this is likely to be close to 15 to 20% of women. Looking at the Bradford data, it's the commonest comorbidity among those who get sick during their pregnancy or postpartum to a degree where they need high levels of support. So among that group who ended up in the MEAC database. Whereas on a regional level, the most common comorbidity are mental health problems. So it is a particular problem that is increasingly faced by the Bradford population. We know that these women have adverse perinatal outcomes. The original sort of seminal trial for this from the early noughties was the A-Choice trial. And this looked at the outcomes of women who were treated for hypoglycemia, so newly diagnosed hypoglycemia in pregnancy, and compared it to those who were left untreated. And that showed a clear and significant increase in adverse perinatal outcomes for women and their babies with untreated GDM. More recently, the BMJ have published a big meta-analysis on this, including over 7.5 million pregnancies. And this shows that even when you treat with diet, metformin and insulin, these increased risks remain. Now, those risks that I just mentioned there are perinatal risks, so things like birth trauma, birth hypoxia, poor blood gases at birth, perinatal, neonatal death. And those are obviously things of massive concern. But what we know is that GDM has massive longer-term consequences for women and their families. These women have a cluster of cardiovascular disease risk factors like obesity, hypertension, and dyslipidemia. They have a 20-fold increased lifetime risk of type 2 diabetes, 10-fold within 5 years. And within 10 years, 50% will have impaired glucose tolerance. This translates to high rates of ischemic heart disease and other cardiovascular complications, which is independent of whether they go on to develop type 2 diabetes. Though if they do get type 2 diabetes, they have a 3 times increased risk of cardiovascular disease. Despite this, gestational diabetes has not been widely incorporated into cardiovascular disease risk calculators that are used in primary care, like Q Risk 2 and 3, which are calculators used at the over 40s health check. Which means that this risk is not in and of itself addressed. And what I see as an anaesthetist, and I think what my colleagues in intensive care and medicine see, are the very end stages of this process, where these patients present in late middle age with renal failure and cardiovascular disease, requiring invasive and hugely expensive treatment that has been coming at them and us down the line for decades. Even more depressingly, the passing on of these risks to offspring results in this self-perpetuating cycle, whereby exposure to the hypoglycemic intrauterine environment, as well as the passing on of genetic risk factors, result in obesity and an adverse metabolic profile in female offspring, which in turn leads to higher rates of gestational diabetes in these offspring. This raises the cardiovascular risk profile for generations of people. Proposed mechanisms of this are really complex, but there are animal models that suggest that intrauterine hypoglycemia results in altered gene expression through epigenetic mechanisms, which seems to result in disturbances in central fetal pathways, which control appetite and energy balance. And the end result is higher rates of childhood obesity and impaired glucose metabolism that begins early in childhood. So what do we currently do about this, and how can we do it better? Well, the first thing to say is that NICE guidance on this is quite conservative compared to a lot of other countries, both in terms of who we screen for gestation diabetes, when they're screened, and what the threshold is for diagnosis. The main reason for this is that there is currently a lack of clear evidence that many of these adverse perinatal outcomes can be altered with lower thresholds for diagnosis. NICE also recommends second trimester screening, but there is increasing evidence that gestational diabetes can begin early in pregnancy, and that it is a separate phenomenon to those group of women who we know exist, and particularly in Bradford, a group of women who had undiagnosed type 2 diabetes. But we think that there is this separate phenomenon of early GDM. That group of patients with early GDM are also recognised to be at a higher risk cohort than those with later onset insulin resistance. And this in turn translates to a proven increased risk of perinatal mortality. And there has, until recently, been a lack of clear evidence to suggest that intervening in this first trimester group can change outcomes. But a big study called the Toboggan study was published in 2023, which has shown that some adverse neonatal outcomes can be mitigated with early diagnosis and management, but this hasn't yet been incorporated into national guidance. As well as being conservative in terms of the timescales for diagnosis, NICE guidelines for diagnostic thresholds are also less stringent than other guidelines internationally. These internationally, several guidelines base their diagnostic thresholds on data from the seminal HAPO trial. This was another kind of seminal paper in gestational diabetes from the noughties. And what this trial aimed to identify was a fasting glucose threshold where there was a clear inflection point leading to increased risk of adverse outcomes. It looked at women who met threshold for gestational diabetes diagnosis and also looked at blood glucoses that fell below this point. And what they found was that there isn't really a significant point at which harm suddenly increases, more that there's this continuous and roughly linear increase in adverse outcomes, which extends below diagnostic thresholds. A healthy pregnancy is a naturally hypoglycemic state, which anyone who has been pregnant or experienced the wobbly, constantly underfed feeling might know. But they had to pick a cutoff for diagnosis. So the International Association of Diabetes and Pregnancy Study Groups chose a glycemic cutoff that confers a 1.75 odds ratio for adverse outcomes, and they set that as a threshold for a GDM diagnosis. In the UK, NICE doesn't use the IA-DPS cutoff and advocates a higher threshold than those based on the HAPO data, meaning that women with fasting glucose level that do confer increased risk, but don't meet our threshold for GDM diagnosis. This is partly because in the UK we use a risk-based screening approach rather than universal screening. But we know from data done by Diane Farrar using the Born in Bradford data that the risk of adverse outcomes related to hyperglycemia remains high below the NICE guideline thresholds for diagnosis. And this is particularly true of women of South Asian backgrounds. It may be actually that a one-size-fits-all approach to making a diagnosis is just oversimplistic. And then part of the dressing inequity in outcomes might mean a diagnostic approach that recognises that this is a really heterogeneous condition and it affects different groups and different people in different ways. Why are our guidelines so conservative? Sorry, that's the paper from the Born in Bradford data. So our thresholds for diagnosis which are recommended by the HAPO data haven't been endorsed by several guidelines, including NICE, because there is unfortunately a lack of evidence that these adverse perinatal outcomes in GDM are modifiable. Although you might infer it from the sort of the original, the very early studies done on gestational diabetes, there is a lack of evidence to show that treatment of women with elevated glucose but not meeting diagnostic thresholds can alter perinatal outcomes. So what about women who do meet diagnostic threshold? What interventions are of benefit? This is an extensively studied area, so extensive that there is a meta-analysis of meta-analyses. And this meta-analysis squared from 2018 found that the only intervention which might be of benefit in improving outcomes for women with GDM was lifestyle modification. So long as there is some degree of glucose control, no other therapy was found to be superior in improving perinatal outcomes. More concerningly, despite a reduction in the risk of macrosomia at birth, follow-up from the offspring of the original A-choice study. So that's that study where they, from the early noughties, where they looked at women who had treated gestational diabetes versus women who were left untreated. Although they had improved perinatal outcomes, it didn't demonstrate any benefit in the impact on childhood obesity and glucose tolerance at 5 to 10 years of age. In the offspring of women who had treated maternal hypoglycemia, suggesting that our current approach to glycemic control in gestational diabetes might not mitigate this impact on longer-term infant health. I'm sorry, I'm being very, very depressing, and it's very easy to become really fatalistic when faced with all the current evidence on gestational diabetes. However, what these studies all looked at were interventions that lasted just the course of a pregnancy on women who have a condition that's really heterogeneous, and in many cases is just the tip of the iceberg of physiological, metabolic, genetic, and public health issues that are hardly likely to be altered by 4 months of giving her metformin. It's therefore not that surprising that longer-term interventions like lifestyle modification are the things which might alter outcomes. But unfortunately, lifestyle interventions are extremely hard and, most importantly, rely in part on our ability to follow up and engage with women who have had gestational diabetes. So follow-up. So NICE guidance for follow-up suggests that all patients with gestational diabetes should be referred for screening at 6 to 13 weeks postpartum using a fasting plasma glucose. If screening is not completed by 13 weeks, then you do an HbA1c, which should be done after this point. If you're below the threshold for diabetes, then you should then check an HbA1c annually for the rest of the woman's life. All women should be referred to the National Diabetes Prevention Programme because they are a group who are at risk of progression to type 2 diabetes. And in our region, this is run by a company called Reed Healthcare. However, in the first year after a gestational diabetes pregnancy, only half of women in the UK underwent any sort of glucose testing whatsoever, and even less had a lipid test. And we're in the process of getting this data specifically for Bradford, but we suspect that we're actually likely to be underperforming in this area compared to the national trend. There is no improvement. No improvement was seen with the numbers tested following the publication of the updated NICE guidance. And there's also evidence that women who have follow-up arranged but don't attend are a group who are specifically at increased risk of long-term cardiovascular disease. In 2016, the National Health Service Healthier You Diabetes Prevention Programme was established. And this aims to prevent or delay the onset of type 2 diabetes in adults in England who are identified to be at high risk of type 2 diabetes. The NHS DPP delivers behavioural interventions aiming to encourage physical activity, healthy diet, with the overall aim of weight loss, particularly for people who are overweight. The face-to-face version of the NHS DPP involves individuals attending at least 13 in-person group-based sessions over a period of 9 months. Early outcome data for looking at this intervention suggest that it does effectively result in weight loss and improved HbA1c readings among people completing the programme, and it is associated with a reduced population incidence of type 2 diabetes. There is a digital version of the service, and participation in the digital service was associated with clinically significant reductions in both HbA1c and weight, and did show slightly lower dropout rates than the in-person service. However, the effectiveness of the UK Diabetes Prevention Programme has not been studied in terms of its ability to reduce progression from gestational diabetes to type 2 diabetes. There have been similar programs done elsewhere in the world. In Australia, there was a program called the MAGDA program. This unfortunately showed that dropout rates were really high. There were some US studies done, and these demonstrated efficacy in women who had a history of gestational diabetes, but these programs took place a decade after the index case of gestational diabetes, by which time, as we know, a significant number will already be excluded on the basis that they have already got type 2 diabetes by that time. the evidence is that diabetes prevention programs can be effective if they're completed and engaged with. But what we lack evidence for is how effectively this works for women who've just had a baby, or for women whose first language is not English, or those who are from deprived areas and may struggle with food security. These are all huge issues. But the first hurdle at least has to be offering the interventions in the first place. Since April 2023, we have received 364 referrals for women with gestational diabetes from Bradford to the National Diabetes Prevention Programme, and they had an uptake of around 50%. Now, at a regional level, our referral rate is much higher than other areas in Yorkshire and Humber. However, percentage-wise, we're performing much worse because our rates of gestational diabetes are so much higher. And what this actually means in terms of our numbers is that only around 25% of women affected by gestational diabetes were referred to the prevention programs at all, and that just over 12% engaged with them in a meaningful way. So as things currently stand, only 12% of women are receiving the only intervention that has some evidence in improving long-term outcomes. So where next? How do we begin to address this? I mentioned at the beginning that my interest in this was piqued through looking at the data from the MEAC database around who gets sick in Bradford, and that there were some key themes. One of which was that postpartum hemorrhage is a big problem. To me, as an anaesthetist, postpartum hemorrhage as an issue feels like something that is much easier to break down and tackle, because there are clear and evidence-based interventions and standards of practice that we know make a difference in outcomes and we can monitor and benchmark ourselves against. It's a problem predominantly of the most acute levels of secondary care, which is ironically also my comfort zone. Gestational diabetes is the complete other end of the spectrum, and it needs collaboration of services from public health, the ICB, primary care services, community services, all focusing on every stage of this illness, from preconception, perinatal, postnatal, and interconception periods, as well as long-term follow-up and diabetes prevention. And this is what we're hoping to achieve through the work of Bambina. Process mapping of gestational diabetes care is in process, with a view to ensuring that we manage these patients in accordance with national guidance in terms of our ability to diagnose, manage, and really crucially, follow up women with GDM. Currently, there's a perception among a large number of patients, and some clinicians too, that gestational diabetes is a diagnosis of pregnancy that ends with the birth of the baby. One of my colleagues who works in Bradford, who's a non-clinician, told me that when she was diagnosed with gestational diabetes in her second pregnancy, she was reassured by her clinical team, "Don't worry, it's just a pregnancy thing." I might have held my punches a little bit when I gave her this talk, had I known about her obstetric history. But I think what her case shows is that we need to challenge this way of seeing this condition and shift the emphasis onto gestational diabetes being an index event that should trigger lifelong screening and lifestyle intervention, and that the end of the pregnancy actually marks the beginning of this whole process. Other areas in the region have begun to automate referrals to the Regional Diabetes Prevention Programme during pregnancy. And this is an intervention that we hope to initiate in Bradford too. However, it's also unlikely that a one size fits all approach to diabetes prevention is going to be what our population needs. Lifestyle interventions are known to be more effective if they're culturally tailored to their target audience, and where the focus is on the family unit rather than one individual. We also know that women who do not speak English, who struggle with food security and childcare provision, are going to find it hard to engage in a 9-month-long programme, which can be delivered on a digital or virtual format, but they might not have IT access. With this in mind, we're collaborating with family hubs in Bradford to firstly begin the process of improved data sharing about where new family units are even located, so we can better plan more tailored interventions to our patient groups. We know from other work streams in Bradford that our population is motivated and will engage with interventions to improve their health, but we also need to think outside the box to find ways to ensure that education and resources reach all population groups and don't just worsen existing health inequalities. And this means tapping into and making the most of existing connections through family hubs and maternity circles, the mosques and community leaders, not just relying on women to make a GP appointment at a time when they're likely to find themselves tied up in the demands of a young family. So it's clear that gestational diabetes is a significant and growing problem, and that it's something that's causing multi-generational morbidity in Bradford. It's easy to become fatalistic when faced with the enormity of the challenge. However, GDM is a diagnosis that can trigger intervention and could go on to prevent poor health outcomes for generations of people, which not only morally makes sense, but like in the face of the enormous costs of managing diabetes and its consequences, it's basically the only thing that makes economic sense. The NHS long-term plan emphasises that we need a shift from hospital to community and from sickness to prevention, and this could not be more true of GDM. And I have definitely not got all or even many of the solutions for it, but I hope what I've convinced you of today, I hope I've convinced you of the scale of the problem, and that it represents as the scale of this problem that it represents, and as well, there's a sliver of opportunity that it gives us to meaningfully intervene in the early stage, at an early stage for our population. We're in the early stages of a cross-service programme aiming to improve our performance in this area, and I'm sure that there's a wealth of expertise out there. So we would welcome your input if you're the sort of person who enjoys marathons, and you think and you would like to get involved. So thank you so much for listening to me today. My email address is on there, so please get in touch if you want to be involved, or have any suggestions or insights, and please let me know if you have any questions.
Thank you so much, Penny. And like, if you've got any questions, you can pop it in the chat for us, please. Got Amal. Amal got
Lots
lots
of
of
questions.
questions. Yes, Amal.
I didn't know if you had muted us all. So yeah, so I'm one of the consultants who works in the gestational diabetes clinic, and I thought it was interesting that we had not heard of any of what your bambino or whatever it is, that none of that's come through to us as clinicians on the floor, neither about mapping the GDM pathway. I don't know whether you've been involved with us at all.
We haven't started the kind of in-hospital stage of the mapping yet. So at the moment, we're focusing on establishing the data for follow-up in primary care, and through the family hubs. We are going to then have a big sort of secondary care mapping session, which we're then going to invite everybody from the gestational diabetes clinic, so that ideally the gestational diabetes midwives and nurses, and so yourselves as clinicians, to come, because we obviously want as much information as possible.
So I missed the beginning. Sorry, who is doing the work in primary care, or what it is? Because obviously we don't want to double up the work, because we're doing little audits of our own to check and see if people are getting postnatal testing, because there was a big shift from testing in the hospital to testing in community, and I don't think the message has quite got out yet from what I've done so far. So yeah.
I think Debbie has her hand up. I think Debbie might know more about this bit than
me. So Amal, various people were invited to Bambina. Vicky Brown attended from an obstetric perspective. I know she's not GDM specific, but at that time it was only the kind of overview of, is this something that we want to look at? So that's why it wasn't so specifically diabetes focused from an obs perspective. I spoke to Vicky yesterday, and she said she was going to talk to you about getting involved in some of the mapping work. So you are absolutely on the hit list.
Yeah. And then I just wanted to make a comment about, you said, the clinicians had told the patients, it's just a temporary thing, you'll be fine. At the end of the day, these are pregnant women. Suddenly their pregnancy has gone from A to Z, and we've become very interventional, telling them to be checking their blood sugars 4 times a day. We have to give them some reassurance during pregnancy to kind of ease their pain in that pathway. And we are, we don't want to go in there saying, oh, you're going to have a stillbirth and you're going to have diabetes and die a horrible death of cardiovascular disease when the poor woman's got a GTT where the cutoff is 7.8 and she's got a 7.9. So, you know what I mean? We do judge it according to the patient. Whereas if you get a BMI of 50 woman, we're going to be telling her, look, you need to sort your life out because you are going to get type 2 diabetes. So I think you need to be understanding that we do cater
and I completely see that,
and we do, by nowhere do we say this is just a short-term thing. We do say, yes, your diabetes is going to go away, but we do say there is a long-term implication of type 2 diabetes in pregnancy, and it is very important you get tested annually and after pregnancy. So there you go.
Yeah, I mean, I guess I completely see that there's definitely a balance to be had between, giving people information that's gonna frighten them, but I also think that you can't really have shared decision making, and you can't really empower women with the information that they need to make those lifestyle modifications at a time when they actually may be quite motivated by the impact that it can have on the sort of future of their family and their future generations. It's a time of opportunity. So I think empowering them with knowledge, I think so long as it's done in a sensitive way, represents an opportunity rather than necessarily a time to terrify them. I think, yeah, so long as it's done well.
That's all my questions. Thanks.
Thank you, Amal. Any more questions?
Thanks, everyone.
No, that's fine. Any more questions there? We will send evaluation form at the end of this week, and also that's include the link and the slides of Penny. So if you got any questions, I'll include Penny's email address as well, and you can contact Penny. That's okay.
Thank you.
Thank you so much, everyone. Thank you, Penny. Thank you so much.
Thank you. Bye.